What is the Holy Grail? It's a metaphorical term for something that is intensively sought after, but impossible to achieve. Simplifying, it's something that everyone seeks, but no one has seen it, except from Indiana Jones maybe, but he lost it, as we know, from the film. How can we put it into the context of mechanical ventilation? I made a really simple search on Monday, and I found that more than 16,000 publications were published on protective ventilation, and more than 600 this year. But what's the problem? The problem is that ARDS-related mortality is still high, and PPC are also common, as Chenga told. So maybe this protective ventilation topic is the Holy Grail. So let's start to chase for it and look into the topics today. The main goals of mechanical ventilation. I'd like to talk about the VILI, the pulmonary protective ventilatory strategies, the individualization, and the role of mechanical power. So, what are the main goals of mechanical ventilation? We all know that we have three main goals. We have to preserve ventilation, gas exchange. We should optimize lung volumes and alveolar pressures, and to relieve our respiratory muscles during mechanical ventilation. And the fourth goal is, due to the manner of mechanical ventilation, that is a double-edged sword, that we'd like to prevent adverse effects of ventilator-induced lung injury. These pathophysiological things led to the concept of pulmonary protective ventilation, because we all know that mechanical ventilation can lead to physical injury by overdistension or atelectasis trauma and recruitment of the lungs. It can lead to biotrauma by the cyclic opening and closing of the little airways, the alveoli. And this biotrauma leads to inflammation in the lungs. So our main goal is to reduce this physical injury and biological injury by optimizing lung strain and lung stress to improve patient outcomes. We all know that low tidal volumes seems to be good in ARDS patients and in intraoperative settings also. So we can conclude these are good for us. What about the optimal pressures? I don't have time to go deep into this topic, into this really interesting study, but it was found that if we fixed plateau pressure and elevated PEEP, so it resulted in decreasing driving pressure. It resulted in better outcomes if the driving pressure was lower than 12 centimeters of water. And it was strengthened by this study that low driving pressure resulted in better survival than high driving pressure in patients with ARDS. So we can conclude that optimal average pressures, especially driving pressure, is good. The third element of lung protective ventilation is the recruitment maneuvers. These are a matter of debate because it's okay that recruitment maneuvers can significantly improve oxygenation, but they don't have any impact on mortality, and they can cause barotrauma and hemodynamic instability in patients, in hypovolemic patients. So it's a double-edged sword also. So this part is really questioned. However, we have some guidelines in patients with sepsis and ARDS on protective ventilatory strategies, and we have also guidelines on perioperative settings, patients under anesthesia. But the problem is that ARDS-related mortality remained high and PPCs remained also common. Why? Because pulmonary pathology is multifactorial and because one size does not fit for all. So the next concept was the individualization of protective ventilation. And Pelosi and colleagues published this really nice paper some years ago. And based on this paper, I think we have to assess, act, and reassess to improve our patients. We can titrate PEEP, we can titrate tidal volumes, we can assess for recruitability, and if needed, we can perform recruitment maneuvers. And we can reassess the results, for example, the gas exchange. However, it can improve patient outcomes, but mortality is still high, and the probability to be extubated is decreasing in patients with ARDS. So the problem remained, despite we individualized pressures, tidal volumes. Maybe because focusing on one ventilatory parameter did not lead to favorable clinical outcomes. So here's our Holy Grail. We put the tidal volume, the pressures, the respiratory rate, and the mechanics in this Holy Grail, and we get to the concept of mechanical power because it includes all these parameters: the tidal volume, the respiratory mechanics, pressures, IE ratio, and the respiratory rate also. So maybe it has a potential role in protective ventilation. So let's go back to primary school and think about the law of conservation of energy that tells that energy can change forms, but is neither created nor destroyed. So we know many energy transformations, and if we think about mechanical ventilation, we can conclude that this is pure physics. When the ventilator pressurizes the system, it generates flow, generates pressure, and this will result in a volume and shape change of the lungs. So during this one cycle, potential energy transfer to kinetic, kinetic to potential. Some heat is also generated, and we can have patient effort, and this will go on and on from cycle to cycle. This is called tidal energy that consists of three components: the elastic, static, the elastic dynamic, and the resistive components. And this is the energy that is delivered to the respiratory system during one single inspiration cycle. How can we measure or how can we count it? The most accurate way is to measure a true pressure volume curve, and the integral area of this curve can be expressed in joules. However, it's hard to handle and implement at the bedside, so we have to use some formula, and according to the equation of motion, we can use this formula with three or two main elements. And if we look into this formula, we see that every component is pressure, so we can write down this formula and everything's okay. Okay? And how can we calculate the mechanical power? We can use the integral of this airway pressure, and this will be, if we multiply it with tidal volume, we'll get tidal energy, and if we multiply it with the respiratory rate, we will get mechanical power. That's the energy that is transferred to the respiratory system over 1 minute during mechanical ventilation. It's quite simple, but not. There are many formulas, so with many advantages and disadvantages. These are really hard to handle at the bedside. That's why a comprehensive and a surrogate formula were also established. However, we have to know the limitations. For example, the comprehensive formula, it requires the inspiratory, the expiratory holds to count. It assumes a linear compliance, assumes constant flow and resistance. The surrogate formula is really simple, but it also assumes constant flow, excludes inspiratory rise time, and the advantage is there is no need for inspiratory hold. These formulas are validated and seems to be useful at the bedside. But okay, we know mechanical power. What is the role? In this experiment, 15 pigs were ventilated over and under a safety threshold of 15 joule per minute. And over the 15 joule per minute mechanical power, all pigs developed whole lung edema, increased elastance, and decreased in a PF ratio significantly. So they found that the safety threshold was 12 joule per minute. In this retrospective post-hoc analysis, two observational studies were evaluated, and they found that high mechanical power is responsible for a significant increase in hospital mortality, and they found the safety threshold as a 17 joule per minute. And in this retrospective study, it was found that not only the amount, but the time over the safety threshold counts. So we have to lower mechanical power, and if it exceeds the safety threshold, we have to change something to reduce the time over it. What about the perioperative periods? It seems that high mechanical power is responsible for postoperative respiratory failure, and also it is responsible for postoperative pulmonary complications also in a significantly amount. But how should we minimize it if it is really important component? Because we know that a 20% increase in tidal volume results more than 30% increase in mechanical power. But what should we do? Maybe reduce tidal volume. What about the gas exchange? The airflow. Okay, the PEEP. What about stiff lungs? What about the EIE ratio? So I don't know. I have many answers, but all has advantages and disadvantages also. So we don't know where we are now, and we don't know the exact role of mechanical power and how to reduce it. Theoretically, volume-controlled ventilation has more impact on mechanical power than pressure-controlled ventilation. It seems that the same ventilator settings result in higher mechanical power under volume-controlled ventilation, but it's just a theory, and it was never tested in a clinical trial. Maybe we can use some sophisticated titration methods, and this is a quite new study that we will start, I hope, in October. This will be the Titron trial, and we will compare electrical impedance tomography guided PEEP titration versus dynamic compliance guided PEEP titration in intraoperative settings during laparoscopic gynecological surgeries. We have the ethics committee approval. It is registered on clinical trials also. I received the message today in the morning from clinical trials. The anticipated beginning of enrollment will be in October, and we'd like to recruit 200 patients over a 2 years period. And I hope we will get closer to the Holy Grail. But now there are more questions than answers, I think. The clinical implications include that association between high mechanical power and ICU mortality or postoperative pulmonary complications is concluded. But there are no RCTs focusing on limiting mechanical power. The clear safety threshold is lacking, and there is no uniformly accepted formula for mechanical power estimation at the bedside. And there is no mechanical power optimizing protocol. So we need further research, and I think mechanical power has the potential to enhance patient outcomes, but it's not yet time for it to become part of daily routine care. This is the end of my presentation, but I hope we will go on. Thank you for your attention.